honor to present Professor Stephen Hunger, who will talk about genetic landscape in children with acute plastic leukemia.
First off, I would like to thank the organizers for inviting me to speak at the meeting. It's a great pleasure and honor to be here. And I'm going to speak about the genetic landscape of pediatric ALL in this session. Disclosures are as listed here. And I think all groups can show curves that look like this, that show the tremendous advances we've made against ALL over the past 50 to 60 years in high-income countries, such that a child diagnosed today at a center in North America or Western Europe has a 90% or better chance of being a long-term survivor, which is very gratifying. And we've started to understand quite a bit more about the genetics of pediatric ALL. And it appears one of the key or very early and perhaps initiating events in the treatment of ALL are, I'm not going to touch that after Seema's problems. So early events are sentinel chromosome translocations that are seen repeatedly in children with ALL. These are almost always retained at the time of relapse and also can transform cells in experimental models. So we think these are one of, if not the first, events of leukemogenesis. However, they are not sufficient to cause leukemia. MLL or KMT2A, which Seema just spoke about, is probably the closest to being sufficient to cause leukemia, but other abnormalities clearly need cooperating events, and we're starting to realize which ones are consistent cooperating events. And then we're also starting to learn more about the genetics of ALL at relapse. I'm going to try to talk about both of these things today. So if I were giving this talk 15 years ago, it was a lot easier to give. There were several major recurrent translocations and aneuploidy, which is differences in chromosome number, that had been identified as so-called driver lesions in leukemia in ALL, and some of those had important prognostic implications. At that time, we were first starting to test targeted therapy, namely the use of the tyrosine kinase inhibitor imatinib in Philadelphia chromosome-positive ALL, but there were no data yet on the efficacy of that. And there were at least a quarter of cases of B lineage ALL where there was no obvious driver lesion identified, and this subset was called by many people the so-called B other subset. Now, giving this talk today, it's more complicated. There are multiple novel driver mutations that have been identified through next-generation sequencing studies of ALL. The spectrum of these lesions, their frequency varies with age. There are a number of more recently discovered lesions that I will go through in some slides that follow, and the prognostic significance of those lesions is currently being clarified. Therapeutically, tyrosine kinase inhibitor therapy is now standard of care in Philadelphia chromosome-positive ALL. As I will talk about this afternoon, is being tested in the new Philadelphia chromosome-like subset of ALL, but there are no standard targeted therapies available in other subsets. So this lists some of the sentinel genetic lesions we see in ALL, and I've called these the classics, ones we've known about for many years. Hyperdiploidy, which can be defined as greater than 50 or greater than 53 chromosomes, or our group, the Children's Oncology group, focuses particularly on favorable chromosome trisomies. This occurs in about a quarter of children with ALL and decreases in incidence with age, and is associated with an excellent prognosis. In contrast, hypodiploidy, so having less than 40 to 43 chromosomes, is uncommon, about 1 to 2% of cases, more common in teenagers, and is associated with a very poor prognosis. And I would say here that hypodiploidy is not 45 chromosomes. So 45 chromosomes or 44 chromosomes is not clearly an adverse prognostic factor. The Philadelphia chromosome, which I've mentioned, the 119 translocation is present in about 5% of patients. It is increased in African Americans, at least in North America, and at least today appears to be associated with a neutral outcome. MLL or KMT2A translocations, which Seema talked about in infants, occur in about 70% of infants, but only 2 to 5% of older children. Generally associated with a suboptimal prognosis in older children, although not as bad today as it was previously. The 17-19 translocation, which is quite rare, occurring probably in less than 0.5% of children, but associated with a very poor prognosis with very few, if any, long-term survivors. On the other hand, we also have the 12-21 translocation that produces ETV6 RUNX-X1, previously known as TEL-AML1 fusion. Again, in about a quarter of children with B lineage ALL, also decreasing with age, and also associated with an excellent prognosis. And then intrachromosomal translocation of chromosome 21, present in 2 to 3% of patients, and associated with a suboptimal or poor prognosis. Now today there is a whole list of newly identified lesions, which I'm not going to go through in detail. As I mentioned, I will speak about Philadelphia chromosome-like ALL this afternoon. The other major recent abnormalities are the DUX4 rearranged group, the ZNF384 rearranged group, MEF2D rearranged group, and PAX5P80R. And there are also other subtypes, as listed below, that are very uncommon. So now we know more and more about the driver lesions that are present in children with ALL. And here we see how some of them vary with age. And this is a complicated slide, but if you look, I won't, as I say, I'm a little reluctant to point, but what this does show is that some of them are much more common in young children, whereas others are much more common in adolescents. Now, we started close to 15 years ago on a project called Target, Therapeutically Applicable Research to Generate Effective Treatments. And the goal behind this was to start to understand the genomics of childhood ALL. And this is a very large collaborative group with investigators from the COG, which I led, the National Cancer Institute, particularly St. Jude Children's Research Hospital, with Jim Downing, Charles Mulligan, and Jingwei Zhang in particular, and also investigators at the University of New Mexico and Nationwide Children's Hospital. We've published quite a bit and have more to publish, and this starts to look at the number of genes with non-silent coding variants at the time of diagnosis. So if you look at the top, we see the number of non-silent, so these are single nucleotide variations in the coding regions of genes that change an amino acid. And on average, there's 11 mutations per sample, and almost all have less than 20, which is that dotted red line. At the bottom are samples obtained at relapse, and here we see that there's 47 on average, and here many have more than 100 changes present. So we see that there are many more mutations present at the time of relapse. This looks at insertion deletions within the coding regions of genes, or indels, and again we see that they are more common at relapse and diagnosis. At the top, you see that there's an average of 5 indels per sample at diagnosis. Again, you have one outlier case with quite a few more. And then at relapse, 13 indels per sample with more of a range. So again, showing more genetic changes present at the time of relapse than are present at diagnosis. And so this tries to look at how these changes happen. So 85% of cases have more mutations at relapse than at diagnosis, and about half of cases have more than twice as many mutations at relapse as diagnosis. There are also so-called hypermutated cases with greater than 100 mutations. Again, this is focused on the coding region. If you look at the non-coding region, the number of mutations is orders of magnitude higher. And these cases that are hypermutated occur predominantly at relapse, and more than half of the hypermutated cases have relapse-specific mutations in the mismatch repair genes involved in Lynch syndrome or hereditary non-polyposis colorectal cancer. And this is a paper, Jingwei Zhang did some detailed work to try to look at how clones evolve from the time of diagnosis to the time of relapse with the target group. And I want to try to walk through this. I'm going to have to use a pointer, so I'm nervous, but I'll try. So in this study, we did detailed analysis of so-called trios, where we had a sample obtained at diagnosis, a sample obtained at remission, which was used as germline DNA, and a sample obtained at relapse. And performed high coverage whole exome sequencing of 20 of these trios who had relapsed early. So we're very focused on the cases that relapsed early after relapse because these have an inferior outcome. And then confirm the mutations with deep sequencing of somatic variants that had an average of 700x coverage. And also in parallel had performed whole genome sequencing. 11 of these cases had a so-called sentinel oncogenic gene fusion like those I presented earlier, and these were all retained at relapse. Now here we're just trying to look at the stability of mutations from diagnosis to relapse. So here very similar numbers to what we saw before, so a median of 10 mutations at diagnosis and 23 at relapse. But here you can see the range, particularly at relapse, can go up to very high, 621 mutations. And the percent of mutations that are present at diagnosis that were retained at relapse overall was 60%, ranging from 0 to 100%. But if you correct this for the hypermutated cases that had more than 150 mutations at relapse, which were 4 cases, it's 75% of mutations. So the overwhelming majority or the significant majority of mutations present at diagnosis are retained at relapse, but not all of them. And then to try to understand the clonal architecture, this was constructed, and I want to present 3 examples that show how clonal evolution, resulted in turnover of the predominant mutations in signaling pathways, reversal of clonal dominance, and changes in the mutation spectrum. So here we're looking pictographically, and I'd like you to focus on this section up here. So the mutations are depicted with symbols. And this, you can infer the presence of a progenitor. You don't necessarily find this leukemic progenitor, but you can infer its presence. And in this case, it has this mutation, which is as listed here, and this mutation is listed here. However, 97% of the cells present at diagnosis had those 2 mutations, plus additional mutations in JAK2, KRAS, and PAX5. 1% had the 2 founder mutations plus a different JAK2 mutations, and 2% had the same founder mutations plus yet a 3rd JAK2 mutation. Now when you look, this predominant clone that was present at diagnosis was gone at relapse. So all of these cells that were the bulk cells present at diagnosis were disappeared or within the limits of detection could not be found at relapse, suggesting that you had killed all of these predominant cells. Similarly, this other secondary clone, here is also extinguished at relapse. But this clone that was only 2% of cells present at diagnosis is the cell from which relapse occurred, and in 2/3 of the cells additional mutations were present as shown here, and 1/3 just these mutations. So you have the same cluster found here, plus this additional NT5C2 and USH2A. Now here we see a second example. Again, I'd like you to focus on this panel up here. We infer a founder cell that has these mutations at diagnosis. 75% of the clones present at diagnosis had additional mutations, as indicated by this square box and the green box, and 12.5% had additional mutations, as indicated here. This clone, which appears to be the founder clone, was extinguished at relapse, but both this clone and this clone survived at the time of relapse. This is the minor clone, and this became the major clone. So again, evolution showing the changes that occur within cells. And a third example, if you focus down here, 92% of cells present at diagnosis had these two mutations, as shown here. 8% had these two plus an additional blue triangle, as shown here. The major clone was extinguished at relapse once again. This minor clone gave presence or survived and gained additional mutations that founded the relapse clone. Now, another recent paper I think is very important, and this is also from Jingwei Zhang, this time collaborating with a group from Shanghai, actually from China, I believe from, and here they looked at 103 matched diagnosis, relapse, and germline trios, so the same sorts of samples we saw before. Most coding, 79%, very similar to what we saw in the previous study, and non-coding, 75% of mutations were retained at relapse, so very similar data from before. All subtype defining lesions, so E2A-PBX1, TEL-AML1, those sentinel translocations were always retained at relapse. But they found 12 genes were enriched for relapse-specific mutation. And they also identified other genes that were commonly mutated at both diagnosis and relapse. And when you look at these 12 genes that were enriched for relapse-specific mutations, 11 of which had been described previously and one which was new, all of them were involved in drug metabolism or response to drugs. So we had abnormalities in corticosteroid receptors, epigenetic regulators that affect glucocorticoid response, nucleotide metabolism enzymes, DNA mismatch repair genes that also affect thiopurine metabolism, tumor suppressor gene, TP53, which affects response to chemotherapy, and a new gene, FPGS, that affects folate metabolism. So what do we conclude from these studies? So first of all, ALLs have about 10 non-silent coding mutations, single nucleotide variants, or SNVs, and 5 insertion deletions, or indels, at diagnosis. More mutations are present at relapse, averaging about 40 to 50, and a minority of cases exhibit a hypermutated genome at relapse, almost always at relapse, occasionally at initial diagnosis, and this is often associated with acquisition of a mutation in a mismatch repair gene. The sentinel translocations and the aneuploidy, so hyperdiploidy and hypodiploidy, are very early and perhaps initiating events that are almost always retained at relapse. And interestingly, there's a strong selection for cooperating events in specific genes, for example, with multiple subclones present at diagnosis with different mutations in CDKN2A, JAK2, or RAS mutations. ALL is polyclonal at diagnosis, so you can infer an ancestral founder clone, but sometimes you can't detect it. And generally there is one or more predominant clone present at diagnosis, and there is one major predominant clone present at diagnosis and one or more minor clones. In almost all cases, the predominant clone present at diagnosis is eradicated by chemotherapy and not detected at relapse. So the relapse typically comes from a minor clone present at diagnosis that acquires additional mutations. Certain mutations are relapse specific or highly enriched at relapse, and there are today at least a dozen genes that have been identified as commonly mutated at relapse and uncommonly mutated at diagnosis, and these genes encode proteins involved in drug metabolism or response to chemotherapy. So what are the potential therapeutic implications of these findings? Well, the first is that these so-called driver or initiating lesions appear to be the best therapeutic targets. They're essential to the disease process and they're almost always retained at relapse. So going after BCR-ABL makes sense. Going after ETV6 RUNX1 makes sense. Going after MLL or KMT2A rearrangements makes sense. It's less clear that going after therapeutically the secondary mutations will be as attractive a therapeutic strategy because of the clonal heterogeneity and the dynamic nature of clonal evolution. It's possible that inhibitors of genes enriched at relapse might be useful in preventing relapse. So if you could look at those pathways that tend to outgrow at relapse, if you had drugs that targeted them, perhaps you would prevent relapse from happening. There has been great interest in monitoring for emergence of mutations in relapse enriched genes. To date, this has not proven effective, but it doesn't mean that it won't prove effective in the future. So one could imagine a sequencing panel focused on those 12 genes in which mutations are almost never present at diagnosis, but highly enriched at relapse. And perhaps if you start to see emergence of a mutation in that, you could start to think about acting on that. Much more study is needed to see if that's a viable strategy, but it's certainly a reasonable strategy to investigate. And again, additional detailed studies of the clonal architecture, including single-cell sequencing and high-depth characterization of ALL in mouse models, will further help us understand the genomics of pediatric ALL. So I'm going to stop there. I again want to thank those involved in the Target project, particularly Jingwei Song, who has been a wonderful collaboration partner for many years, and I'd be happy to answer any questions. Thank you. I think the people who have the hardest job are the ones running around with the microphones.
Yes. Thank you for the comprehensive talk. Given that most of the relapses occur from the minority mutations that been shown, should we change the way that we detect the minimal residual disease? That's to say, to move to detect the mutation and the proportion of each mutation, and then at day 15, day 30, whatever, we redo it again and see how the MRD is evolving or not?
Yeah, so if I understood the question, it's really given that the relapses occur from minor subclones present at diagnosis, should we change how we monitor cases? Our monitoring of cases for response and initial diagnosis really focuses on how fast that dominant clone is eradicated. And we clearly know if you eradicate the dominant clone quickly, it's better than if you eradicate the dominant clone slowly. But I think your question is a good one, is if the minor clones are important, or should we try to develop strategies to monitor that clone? There's been a great deal of interest that so far really hasn't paid out on trying to flow sort samples at the end of induction to test for the presence of minor subclones. I think that the fact that that hasn't paid off yet doesn't mean it's not a good strategy. We may need better technologies, and single-cell sequencing certainly has that potential to really study, are there cells persisting at the end of induction that contain mutations? If so, is that a negative prognostic factor? One would think it is, but I think one has to prove it is. So I think your question is a very good one, and it's one a great deal of people are interested in. And we just need to harness the emerging technologies better to actually do it and test to see if it's a viable strategy.
Thank you, Professor, for the lecture. I'm just confused about two slides. In one of the slides, you have said that about 60 to 75% of the genetic mutations and the diagnosis retained at the relapse. And after 2 slides, you're clarifying the progenitor clones, and you say that about 97% of the progenitor clones have disappeared at the relapse. Could you clarify this point?
Sure. I think that's a good question. Is there an internal inconsistency there? And on the one hand, we say that the mutations present at diagnosis are retained in relapse. On the other hand, say that the major clone present at diagnosis disappears. And I think that is because many of the mutations at diagnosis are in these ancestral clones, and those are retained at relapse. So these early events in leukemogenesis probably are almost always retained at relapse. It's some of the secondary mutations that are not. So when you look at the diagnostic sample, let's say it has 5 mutations, 4 of which are in the ancestral clone that all the leukemia cells share. So at relapse, the 5th one, which defined the bulk population at diagnosis, may have disappeared, but the other 4 were retained. I'm not sure if that explains it well.
Thanks a lot for this lecture. I have actually 2 questions. The first, how do you deal with cases with intrachromosomal amplification 21? How do you stratify them? And also, if you find any of these minority genetic abnormalities in your patients, and then during your MRD or during following their minimal residual disease, you find them still persistent, would you upgrade your patient or you just follow the regular stratification? Thanks a lot.
I'm sorry, I had trouble following the questions. Could you go through them one at a time, perhaps?
Okay, how do you deal with cases with intrachromosomal amplification 21? That's my first question. How do you stratify them?
How do we stratify cases with, sorry?
Intrachromosomal amplification 21, Ronix 21.
Okay, sorry. So intrachromosomal amplification of chromosome 21 in our hands in the Children's Oncology group, we treat many patients with low intensity therapy. And I think it's very clear that children who have intrachromosomal translocation of chromosome 21 don't do well if treated with low intensity therapy. So we consider them all to be in the high risk or intermediate risk group at diagnosis. And if they are treated with high risk or intermediate risk therapy, they do relatively well. So it appears to be a mutation, at least from our studies, that should make you not a low risk patient, but doesn't make you a ultra high risk patient where you would consider transplantation or something like that. And then your second question was?
Yes, my second question. Besides the normal or regular genes and mutations, chromosomal abnormalities that's included in the regular risk stratification, if you find any of these minor drivers that you just mentioned during your follow-up for your patient, would you consider your patient a high risk and react upon them or not? Thanks.
Yeah, I think that's a good question, and I think we don't yet know the answer. Generally during therapy, we monitor patients either based on flow cytometry, so the presence of a diagnostic immunophenotype, or based on the common sentinel chromosome translocation, such as monitoring for BCR-ABL or monitoring for ETB6-RUNX1. We don't really know what would happen if you started to see evidence of cells with mutations in JAK2, for instance, or NT5C2, and there are some anecdotal cases where some of these point mutations can be detected and then disappear. So I think one really needs to perform careful studies of how, of what it means to see mutations during active therapy before using it, before acting on it clinically. I just don't know the answer at this time.
Yes, please. I would like to ask, if you find a mismatch repair during this study, would you change the maintenance or the fibrin-based maintenance in these kids? Because I guess in Egypt we have a high rate of mismatch repair gene defect. That's why I was concerned.
Yeah, so I think we're talking about two different things. So germline mismatch repair defects are something that is very different than what I'm talking about, which are acquired mutations in mismatch repair genes. But I think one of the questions that people wonder is the maintenance therapy we use today is very repetitive. 6-MP and methotrexate for anywhere between 1 to 2.5 years, with or without vincristine and corticosteroids. And if you knew that a patient was developing mutations that could affect thiopurine sensitivity, might it make sense to vary the maintenance therapy? And there's a very old St. Jude so-called rotating pairs maintenance that use different combinations given every week, and one wonders if that could help inhibit emergence of these mutations that affect thiopurine metabolism. So I think we can probably learn a lot more about how to optimally deliver maintenance therapy, and part of it may be trying some different things during the course of maintenance therapy. But germline mutations in mismatch repair genes, particularly biallelic mutations, congenital mismatch repair deficiency, are very different than the acquired mutations. We have one more.
So, thanks for the great presentation. In the model that you have shown, where basically the secondary event could happen in the subsequent relapse, is it known what's the effect of those mutations on the phenotype, since our basic model for following residual diseases by flow, at least in North America, is it known if there is any shift in the phenotype or change with those mutations?
Yeah, if I understood the question correctly, does this change in the spectrum of mutations change the cell surface pattern expression such that clones wouldn't be detected by flow cytometry? And I think in general, the answer to that is no. In general, it appears not, but they don't change the surface expression, with perhaps two predominant exceptions to that. The first are cases with MLL or KMT2A rearrangements, which are, I would call them very plastic. They can gain and lose antigen expression, and can even switch to myeloid expression. And the other is one of the newly recognized subtypes, ZNF384 translocations, which also is associated with mixed phenotypes. So those cases, you can see evolution in the expression profiles such that leukemic cells would not be picked up by monitoring the diagnostic immunophenotype. But for most, it appears the diagnostic immunophenotype is very stable. Great. Thank you very much for your attention.
Thank you very much. It's just to notify that unfortunately Dr. Sally Fishawi is having a family mishap, and she will not be able to give her presentation today. So if you don't have any question, we're going to close the session and return back at 1 p.m. after the prayer. Thank you.